So let's talk about the basic anatomy of the knee joint.
Great.
So first things first, what are the bones around the knee joint?
Great. So you have the femur.
Yeah.
You have the patella.
Yeah.
You have the tibia.
Yeah.
And you have the fibula.
Okay. Major ligaments around the knee.
So around the knee you have the medial collateral ligament, the MCL.
Yeah.
You have the lateral collateral ligament, the LCL.
Yeah.
Then you have your cruciates, so the anterior cruciate ligament,
ACL.
ACL, and the posterior cruciate ligament, the PCL.
Okay. And major muscle groups. We won't name them all, but what are the main muscles that people have generally heard of?
So the quads and
Yeah.
the hamstrings. And then you have your calf muscles as well below the knee.
Good. All right. Let's see if I can draw a knee and we'll see if we can fit all these parts together.
Great.
And when we draw knees, I'll draw the bones first. You let me know if you think I'm anatomically correct. How's that?
I like it.
That's what we call a view from the front. And knees have 2 dimensions, so we should always, for teaching purposes, I always like drawing a knee sort of from the side as well. And then we can draw the outline sort of the shape of the knee, sort of like this. And how's that?
Looks great.
Okay, so bones, we have our
Femur.
Which is a thigh bone. And the lower bone here is called?
Tibia.
Yeah, and?
Beside it's the fibula.
Fibula, a little small bone. And?
The kneecap, so patella.
Patella, which is here. Or your kneecap. Patella, right?
Mm-hmm.
I think people know their major muscle groups, so we know that our quad muscles run up in the top. So your quads are the front muscles, your extensors, your hammies are in the back, hamstrings are here. Then you have your lower leg, calf muscles down here.
Perfect.
Want to concentrate obviously on our ligaments. Let's see if we can get these ligaments in the right order.
Great.
So, first ligament is, we separate ligaments the way I see them, sort of your outside ligaments and your inside ligaments.
Yep.
So, what's this one called?
That would be your MCL.
That's right. And what's this one out here?
Your LCL.
Yeah. MCL because it's on the medial side, and LCL because it's on the lateral side. The tricky one is the 2 that live inside the knee, called your ACL and your PCL. And they sort of basically live sort of like this. And they kind of cross over a bit like this, right?
Yep.
Now, I'm going to draw on this view here the ACL like that. How I remember it is that it starts in the back and attaches in the front. Sort of a bit of an angle like this. The PCL runs a bit like that, the other way. Okay?
Okay.
So this is your ACL here, and that's your PCL right there. So here we have your basic anatomy.
Okay.
I can scrub this.
Yeah.
So what's a meniscus?
Great question. So in layman's terms, a meniscus is sort of these discs that sit on top of your tibia here, and they act in a shock absorbing way to sort of take stresses off your knee so that you don't have your knee grinding bone on bone.
I often like to draw a meniscus sort of like this, like sort of C-shaped little pads, right? They take up space, okay? So it's a meniscus, and a meniscus tear is a common injury I see.
Yep.
Often you hear people get surgery because they've torn a meniscus, so they have to have some of their meniscus taken out. The word cartilage is an interesting word because so a lot of my patients tell me they have what they call a torn cartilage.
Right.
Cartilage can be confusing because what does cartilage mean to you as a medical student? It's not the meniscus. So what does cartilage mean?
So as a medical student, cartilage is defined based on the cells that make up cartilage, chondrocytes.
Mm-hmm.
So they have to have specific cells that make up the structure.
And the location of the cartilage on a knee?
Is generally along a bone.
Yeah. So I'll kind of draw it in here. So bones have a cartilage lining, sort of like on the end of chicken bones, sort of like the white stuff. I can't really draw it very well. Does that make sense?
Yeah.
So I sort of draw it like this. So your bones have this protective lining that's, and both the tibia and the femur have it. Does that make sense to you?
Yeah.
So, by definition, this is what's called articular cartilage.
Right.
Or it's a cartilage that belongs to the bones.
Yeah.
The meniscus, some people refer to it as meniscus cartilage.
Okay.
I call it, this is the shock absorbing pad.
Okay.
So in osteoarthritis, the kind that I see that's common for our weekend warriors or older patients that just wear out the joints. It's not their fault. They're in their 50s and 60s and the joints are starting to wear out.
Yeah.
I'll put you on the spot a bit here. I wonder if you can tell me, statistically, if you're going to wear out a joint, what part of the joint would you wear out? Would you wear out the whole joint at once or maybe one part first?
Yeah, I think we tend to wear out the medial aspect of the knee before we wear out the lateral.
Absolutely true. Tend to wear out the medial side first. And when you wear out the medial side, what happens is you wear out the meniscus. So the meniscus here, I'll sort of take away some of that. See what happens? It gets thin, it gets diseased. Maybe my patient may have had a meniscectomy or some surgery from years and years ago. And then they can start to wear out some of the protective articular cartilage here as well. Okay?
Yeah.
So, then what happens? They get into eventually a situation where they lose that nice cushiony space. And so what's happening to the knee here?
You're losing joint space.
Yeah. And so now we have loss of joint space, and we can clearly see that on tests including x-rays.
Right.
Standing x-rays, MRIs even.
Right.
I like to, as you know, just get regular x-rays. You can really see that compression. I often show it to my patients. I say, look, you have narrowed the joint space down. You may not be quite bone on bone, but you're getting pretty close. You've seen that with me, haven't you, in clinic, right?
Plenty of times.
Yeah. So when you have that situation happening, my patients get unhappy because they start to feel unstable. They start to feel their knees shift back and forth. You watch them walk down the hallway, their knees are literally shifting in the sideways direction.
Yeah.
You almost see it when you watch them walk down the hallway. This is where I help them by trying to give them some advice, and this is where getting some sort of brace that can literally unload the knee can help. So they're called unloading or offloading braces. So the theory behind an offloading or unloading brace is to design a brace that has some structure, and it may have a hinge mechanism. The hinge may be on one side or the other side. It may have a type of strapping system that runs to the knee joint, so that biomechanically when you walk up and down the hallway, as your knee wants to collapse inwards, the way these unloading braces work, they provide a biomechanical pressure to in effect try to open up that joint. Does that make sense to you?
Yeah.
Yeah, I think these braces can work really well if fit properly, so that's one treatment option that I often prescribe my patients is something called what we call an unloading knee brace. Okay? All right. So, common injury that I see a lot, probably the commonest injury I see is MCL sprains.
Yep.
Let's go back to our knee. So here's your knee. And so where's our MCL located? It's right here. Lives big, strong, like a rubber band ligament through here. So the MCL stabilizes your knee on the inside.
Yep.
So we do a test clinically. If I suspect someone has a torn MCL, we can literally do this stress test where we can take the knee and push on it and see what happens to the inside. And if the knee MCL is only partially torn, that test can cause pain, but you don't perceive any instability.
Right.
I have some of my patients that can actually tear their MCL. They literally tear this MCL pretty much completely, if not all the way, mostly all the way, so it may just be hanging on by a little bit. And so when you do this test and you test their knee, what do you think happens?
You have a very soft endpoint and a lot of laxity with
and which way does the bones go?
So it opens up the joint space immediately.
Almost might be a little bit being a bit dramatic, but this is
What you feel.
this is actually what you feel. So you're pushing the knee, and so the knee can actually get in a situation like this. You see what's happened? It's sort of the knee's gone kind of crooked. So it's a common injury. So what's the mechanism of injury in any sport? How can an athlete tear their MCL like that?
Usually a big lateral load to the knee or a twisting mechanism would be two that I would think of.
Sure, and this is what I see. I'll see a hockey or football player being contacted on the outside.
Yeah.
Or you could do this to yourself. You don't need someone to run into your knees. Give me an
Yeah.
example of how you can completely tear your MCL without having anyone run into you.
If you just caught your skate edge in a wrong way, fell into the boards, anywhere that you're twisting your knee and catching it and holding it in a fixed position, so any pivoting sport really, you can do a lot of damage to your MCL.
Skiers do this. When they fall, catch an edge, wipe out skiing,
Yeah.
their knees will collapse inwards, will tear their MCL. Okay, let's talk a bit about ACLs.
Sure.
What does ACL stand for?
Anterior cruciate ligament.
Again, we'll start with our basic knee anatomy. And there. So your ACL lives where? Lives in through here. So, an ACL provides front and back stability
Right.
to the knee. Athletes who have torn their ACLs get into trouble changing direction or stopping. And it's a little bit of a non-logical reason why that is.
Okay.
So I'll try to explain it to you, and you tell me if this makes sense.
Okay.
When you're running, so here you are running, chasing a ball or something like that, and you want to stop and change direction. Athletes often get in trouble because they can tear their ACLs without anyone running into them.
Right.
Just the action of stopping, changing direction, something happens to their knee. So what muscles do you use when you're running and you have to stop and change direction? Think of it. Think of, just visualize you're this guy running and you have to stop. You have to stop on a dime.
Right. I would go with your quads.
Yeah. You instinctively, as a good athlete, you'd fire your quads, right?
Yeah.
So you fire your quads. You fire the quads tight. Here you have your quads in through here. And if you fire your quads hard enough, you can tear your ACL. Does it make any sense how that would happen?
Not intuitively.
Yeah.
No.
So it's not intuitive, is it?
No.
Here's the reason why. You see how I drew this picture?
Yeah.
And you see how I drew a knee, and you fire your quads, whatever, maybe your kneecap pops up a little bit, what happens to your ACL? Well, athletes don't play sports with their knee straight.
Right.
Athletes play sports with what?
In a power position.
Which is
Flexed.
flex that athletic knee bent position.
Yeah.
So let me redraw this part of the diagram here, if I can. In that power position, you called it, right?
Yeah.
That athletic, that ready position. So here we have an athlete with their knee in that nice knee bent ready position. So you fire your quads. You fire your quads to stop. The quads causes a force vector up in this direction. This is now a little bit of physics. Do you understand that, right? Because you're shortening the muscle. Now, your kneecap serves as a little bit of a movable biomechanical pulley system.
Right.
And there's a structure that attaches the kneecap to the tibia called
Patella ligament or patella tendon,
yeah,
depending on who you ask.
Right there.
Yep.
I think it looks like that. Now what happens in that athletic knee bent position, 60 degrees maybe, 45, 60, 90, depending how athletic you are. The force gets transferred through the patella. This is biomechanics.
Right.
With me so far?
Yep.
And you get a force that goes that way and it crosses, turns a corner of your kneecap.
Right.
There is, however, a bit of a net resultant force in the forward direction.
Right.
Not a big force. Does that make sense now? Right? You pull your quad. So I want you to explain that to me so you can tell me how you understand that. So here's your ACL.
Yep.
So you go and explain through this picture now how you think someone can tear their ACL if they just suddenly stop.
Yeah. So somebody's just stopping. They're going to be firing their quads as we showed in this picture here. And that's going to pull on the quad, shorten it. The quad's attached to the top of the patella. And as you know, the patella has a ligament here attached to the tibial plateau. So you have a force vector from the shortening of this muscle that points up the thigh. And then you also have from the tension in this ligament a force vector this way. So at the end result, you're pulling the tibia sort of in this direction.
And a violent enough force can snap your ACL.
Yeah.
And then the tibia shifts forward. And that's how a lot of athletes tear their ACLs.
Right.
This has a mechanism, by the way, in case you want to know this. It's sort of advanced biomechanics. Quads active mechanism of tearing your ACL. Get it? You activate your quads.
Yeah.
Pulls the tibia forward. Now, I'll tell you why I thought it was important for you to understand this mechanism, because if you're going to try to fit someone with a custom ACL brace,
yeah,
if they have an ACL tear, they have surgery, what do you think the brace needs to do?
It needs to support the tibia.
How?
In a way that prevents it from sliding along the force vector that it wants to.
Forward.
Yeah.
So this is why when people tear their ACLs, the little small inexpensive knee sleeves or the small hinge braces don't work.
Right.
The brace needs structure. It needs to have a certain type of what we call a shell design.
Yeah.
It's got to have a biomechanical hinge sitting right here. Make sense?
Yeah.
And the hinge has to be attached to some type of other shell or strap or both system that's attached to the tibia here. So when you see these ACL braces, they have that characteristic look. And then when we fit them, custom made, you have to really make sure that the tibia part sits flush.
Yeah.
To the point where there's very little movement, but the brace has to be comfortable enough.
Right.
So interesting concept. I think once my patients understand that, they understand why they need a brace.
Yeah.
Once I explain this to students like you or other doctors, they understand why these braces can help.
Yeah.
Okay.